Much for this invitation in this prestigious meeting we have over the years. And of course the question is very crucial as the TAVI procedure becomes even more frequent procedure in all over the world actually. We know that since the procedure started to evolve, there was definitely a requirement to meet some volume numbers in order to have some good results. And we know from our experience that the more complex the procedure is, the more volume you actually need to do in order to become very professional in what you're doing. However, TAVI, we all lived the evolution in the technique, the evolution in the risk of patients. So I think this brought the question whether you need to do a lot of numbers in order to have some good results, some quality results, and at the same time not to exclude a significant number of patients which do not have access to the facilities that actually produce the procedure. So this is a major question. Maybe in overseas, the United States, the question comes to a different point where you have the funding but you don't have the hospitals. Here we do not have increased the funding, but still we have a problem because we have a lot of hospitals who are producing a low volume of procedures, and we don't know if they are doing the high quality results that we need to do and to have. So this is a big question that comes into clinical practice and into real life, and it is whether the procedural volume have a substantial impact on outcomes. And someone may ask, why do you ask this question? Why did we bring this issue? It's obviously that it does. Well, over the last years, we have some different, I would say, results from some registries and overview of registries that were already published, and recently new data came out. So we start with the early US experience, which look at the TVT registry report from 2011 to 2015. Significant number of hospitals, 395 hospitals, 42,000, 43 almost thousand TAVR cases with the old although valves, the SAPIEN mostly, SAPIEN XT and the core valve. And when we look, it's very difficult, but we'll see later. When we look at the curves as far as mortality, stroke, bleeding, it looks like as you go on the right side, which is you increase the number. This is the pointer is not working, but anyway. So as you go on the right side, you see that the mortality, the stroke, and everything goes down. Is it okay now? Okay. So basically what we see is that we have a decrease as the number of volume of patients in the hospital per operator. You have a decrease in the incidence of mortality, bleeding, stroke. So obviously these data support the issue that you need more procedures to have a reduction, like we see here, reduction in mortality by 1% as you go up to 300, and this is something that is expected, I would say, from the data we know. And the same again from that registry was published in 2017. You see the reduction in stroke by 0.5% as you grow to the numbers to 300. And this is a procedural sequence number. That means it reflects also the experience of the operator mostly. Interesting was the finding in that registry when it was published that when you look at the transfemoral outcomes with this large first generation, the significant difference remained for the bleeding and the vascular complications in cases where you have a small learning curve. And this is true, and this is what we all lived over the first years of the experience with the TAVI procedure. So the question came out, although, is in this publication, is whether this is actually a volume relation outcome, or it's just you need a more learning curve before you know a very complicated procedure, and that's why you have these results. So there was some limitation, of course, in that registry. It's a registry, first of all. You have all generations. Maybe the screening was not done the way it's done now. Remember, we're looking at echo initially. Now, there's no way you can do the procedure without having a CT. So actually, there were some questions whether, if we look at more at recent devices, like the SAPIEN 3 valve, where the results would be a little different. And in that registry and evaluation of the data that we have, in the same registry, the TVT registry, they look at what happened with the SAPIEN 3 valve, the new valve from Edwards. And they evaluate case sequence analysis in order to see what the impact on the learning curve was with this valve, and volume outcomes, which actually relate to the center volume regarding the procedures that were performed with the TAVR. And it's interesting that here, as you see, we did not reach a significant difference as far as the 30-day mortality with the SAPIEN 3 valve in the case sequence number, reflecting the experience of the operator, and again, here also as far as the stroke. So this is an interesting finding, which is different from the one before. And then if we look at the volume of the hospitals, we have those quartiles, and it's less than 25, 25 to 50, 50 to 100, and above 100. And we see that the difference in mortality, in 30-day mortality, is not different by looking at this registry with the SAPIEN 3 valve. Again, we have the data with a 30-day stroke, and again we see, looking at the quartiles regarding the volume of the hospital performing the procedures, 25, 25 to 50, again you see no significant differences. And if we look at the new hospitals that started, the new TAVR hospitals, again with the same valve, then again we see that we have no significant differences as far as the 30-day mortality. So there is a question that comes out, why now with the SAPIEN 3 in this registry, again it's a registry with several limitations, why do we have some different results from what we know from the PCR procedures? And there's no doubt that in that cases we know that volume makes a very significant contribution to the outcome. I think what the author suggested is basically that in those who are performing the TAVR, there's significant differences the way and who is doing it, how you do it, who is deciding what to do. Here is you have the basic training, you get the interventional training. It's a good training, but still, you know, it's the operator who decides it's what to do, maybe have a consultation with the surgeon before deciding, or the patient in some countries on his own gets the consultation with the surgeon before decides what to do. But in the TAVR, we have a whole team here, and this is a different approach, which obviously filtrates some of the decision making, and maybe it's the best way to have this results without depending so much, after, of course, an official training, after the proctorship, on the volume per se. Also, I want to make a point that the volume does not mean quality all the time. You need to have quality assessment, and of course, volume is a surrogate, and you can accept that because in several countries you don't even have a registry of the outcomes. And we know that we don't have this registry for the surgery, for example, which we should sometimes. But at least in Greece, at least for the TAVR, you need that, and I'm glad we have it at this point in our country, or obviously in other countries. And then came this publication, New England Journal of Medicine, 2019, April, and basically they update the finding that we have from the published data in 2017. And now we are talking about 113,000 TAVRs. We're talking about transfemoral access, 84%. So hopefully, you know, the idea was to get the same results with the SAPIEN 3 and see what happens and maybe have some changes. As we see here, again, we have these quartiles as far as the hospitals, procedures 5 to 36, the lowest, 37 to 54, 58, and then about 8 to 100 to 370. So this is a very high volume, but this is a very low volume, which reflects, although, the average volume that we suggest a hospital will do in Greece, since the meeting is in Greece. I'm giving some inputs also. So we are basically here as far as a country, and in the United States, probably the average, the medium, I think I'm reporting that later, is about 60, 57, something like as the number. Here we see that, to give an idea what is operated with TAVR now in the United States, looks like we have the age, it's intermediate risk, but also the age still is around 76 to 87, so it's definitely above 75, as we see here the ranges. We have here STS score, which is, as we see, is medium 5.4, so it's between 5 and 6, what we have also in our country, in the KC. And we see here that the high risk and intermediate risk contributes mostly to the decision to have the TAVR. The median annualized volume from that registry, the analysis that we have in the New England publication, is 54. Lowest volume, average 27, highest volume 143, and this is from the United States data. And what we see here, this is my line, but it looks like when you go as an operator experience, when you go around 50, the lines start to get flat. So I would assume, it's an assumption, you cannot prove it, that around this number, the 50, is what you actually see the lines and the percentage of reduction to become flats. And I would like to have your comments afterwards with our experienced operators if that number reflects truly cut-off criteria somehow. And again, we can see that as far as the volume, looks here that you are above 150 where your volume, the curves start to make flat or doesn't make any difference as far as the relative reduction in mortality. Same here as the 30-day mortality. Around here, the curves become flat, I would say. So as a continuous variable, the procedure volume was inversely associated during the analysis of this data with the mortality of 30 days. Mortality was 3.19 and 2.66 in the highest, 3.19 in the lowest. So the odds ratio is above 1. And the findings were similar in a sensitive analysis, excluding the first year of transfemoral. And again, the vascular complications in this analysis were increased in the lower centers, volume centers. So I think this came out the last month from the United States. It does require hospitals who are actually performing the TAVR programs already to have 50 procedures per year, including more than 20 TAVRs. So the volume still is appreciated as a significant factor. And I think there's also a change for our experience that a single surgeon is now enough to evaluate the patient whether he's going to go for surgery or for TAVR. So in conclusion, procedural volume requirements is still important. It is still more than you do, the better you do it. I think that's the conclusion. Overall, volume is not a perfect surrogate for quality, but it's the best that we have. And I think we should continue, record our results in order to find better indices than just volume to be able to evaluate the procedure and the centers who are doing and the operators the procedures. Thank you very much.
Thank you. Thank you very much, Professor Vavuranakis. Any comment? Short comment? Can I ask something, Manolis? Are the requirements regarding procedural volume connected to reimbursement in any country?
You mean the United States? Or the United States probably have the expert, but I think if you don't meet those criteria, you are not going to be reimbursed. George, what do you think? If you get. Let's see another opinion. But you register all your data, I assume.
Well, just to stay on the subject, yeah, it's true that there is some relation, but it's not enforced prospectively. So there is periodic audits, and then you run the risk of, having to do some return of the reimbursement. On the other side, the more practical side, I want to explain a little bit why there is difficulty for centers to accept that. Is that the more dissemination of the procedure, the more hospitals the more remote areas are covered, and nothing is taking that away. Similar to, let's say, you have a TAVI center in Greece, in Rhodos, let's say, or in Ioannina, or in Alexandroupoli. You cannot centralize everything to Athens because distance is a problem. Same in the United States. Many areas are very far away. So if you enforce these things, all of the state of Dakota, for example, is not going to have any center. Now, how about that? So the other aspect, more importantly, is when you start a program until you build the volume. Let's say you build it in 3 years. The first year, you're not only just getting 50 cases, you're getting 40 tough cases, because these are the cases everybody just refers initially. Because a new program, you're always going to get the tougher ones. So it's interesting, when you have a smaller program, you're more disadvantaged towards the tough cases that you get referred. And as the program increases, the mentality of the community and the referring doctors is that, oh, this goes pretty well, let's refer a few more patients. So then you start getting a moderate risk or the intermediate risk, and therefore you decrease and we see that with PCI, you decrease the mortality. It's the same exact thing that happens to PCI. So that paradox is what really makes it a little difficult to adopt and right away say, you know what, let's close down every center that doesn't have less than X amount of numbers. Well, every center used to be a small center before they became a big center.
So
Thank you.
George, so the only, I assume the only way would be to evaluate case by case by an independent committee and see the risk of the patient, the outcomes, because otherwise you don't know what you interpret. If you do a few cases, 10 cases, 20 cases, and you have 2 deaths, you're out. I mean, mortality is huge.
Yes.
Exactly as you say, it's a little bit of it more difficult to evaluate the smaller programs, and the smaller programs do need a more of a surveillance, let's say, supervision. And perhaps you have a way to deal with smaller programs in one area that there are many programs. Let's say within Athens or within New York or within an area that you don't have the geographic issue. But when the geographic issue comes into play, there's a lot more social factors than the numbers that's going to make a program exist or not exist.
Manali,
Do we have time for another comment?
okay.
Yes.
Do we? Yes.
We have some time. So,
We have some time.
Manalis, I want to ask you.
It has been fashionable to talk about centers of excellence. How far are you going to go with that? I mean, if we have to set up centers for excellence for TAVI and centers for excellence for valve surgery, and then we have to set up centers of excellence for coronary bypass, and there is no end to that. In the small hospital I'm working, we're doing 2 to 3 cases of TAVI cases a week. The total number of cases done is around 150. We had 3 deaths. I'm not doing that. I'm a surgeon. The cardiologists, they're doing that. Well, the cardiologists involved in that procedure, they are good clinicians and good invasive cardiologists. And we had some good proctoring. Dr. Vavuranakis was one of the guys that helped us to start. So we have proctoring of that level. We had 3 deaths. A patient died because of perforation of the left ventricle. I was covering the case, didn't give me time to open the patient up. The patient developed electromechanical dissociation very fast, had a terrible left ventricle. There was no way to go on bypass with this patient and come off bypass. That was the only cardiac death. The second patient died because he had a rupture of the pulmonary artery from the pulmonary line balloon. They inflated the balloon in the periphery. He bled inside the right pleural cavity. We opened the chest. We removed a couple of liters of blood from there. We gave blood and so forth. the patient died on the table. The third patient was slightly confused. The procedure went well, and 24 hours later, he fell off the bed. He bumped his head on the floor. He developed an hematoma. They aspirated the hematoma, and he died later of edema of the brain. Anyway, I think it seems like with experienced invasive cardiologists and with good proctoring, you don't really have to have huge numbers to achieve some good results, I think. You have proved that with your presentation.
Like I said, it's difficult to evaluate the results and based on the isolated events that you mentioned. For example, of course, proctoring is on like 20 cases. I think afterwards you're on your own, and it depends. Rupture of the pulmonary artery. I mean, this is a very unusual case. The number-wise maybe not be high, but at the same time, the complication needs to be evaluated. Why did it happen? So I cannot answer about the number by just taking the example of one center. I think we need more experience, and like we said, we need to evaluate in the social environment where the hospital works. It's different if you work in an isolated area where there is not experience, like in an island, for example, Rhodos, and different when you work in Athens, where the facilities are different. So I think it's hard by just using one center to determine. I think the data supports that definitely there is a correlation and association between volume and mortality. At the same time as the technology evolves, probably we will be less needed on the experience because you are growing the experience slowly. At the same time, it's becoming an easier procedure. It reminds me, we are not reaching this point. Why, with the PCI, when we started to do the left main, the OR was open, the surgeon was there. Now you just do it and you continue. We did not reach this point yet, but I think it will go slowly to the point where the experience will make a significant contribution versus volume as a center. It will be more operator who can do than the center volume. That's my...
Can I just make one more statement? One statement. I agree with most of everything that's been said. I think 90% of TAVI now is pre-planned, and the results are good based on the training, on the company support, and based on the thoughtfulness of the whole team. However, we do know there are certain cases that are very high risk or higher risk, alternative access, low EFs, shocky patients. And maybe these are the types of patients the low volume centers shouldn't take on initially, but there should be freedom of people to discuss these cases and maybe transfer, if possible, these patients to other centers to let the more experienced centers handle them until the low volume centers come up to speed. I think we have to be honest with our own skills of our team.
Yeah, the other point is there's some statistics to think about here. If you have a low volume, it's hard to get a reliable estimate of what your mortality truly is. And that's one of the reasons that 50 has come up in the NCDR number. So one reason for not doing 20 cases a year is if you have one death, that automatically gives you a 5% mortality, no matter how good you are in the other 19. The other point is if you look at the volume mortality curves from that New England paper this year, the one thing you'll see is there's a lot more variability in outcomes in the lower volume quartile. So although there are problems ascertaining each individual center's true mortality, there is about a 20% likelihood, if you're in the low quartile, that you may end up in a center with 12% mortality. That's a little worrisome. Whether that point estimate's correct or not, if I were having a TAVR, I'd look at that and I'd be very scared.
Mark? Yeah, thank you.
Thank you very much. Professor Vavuranakis, dear colleagues, as we're talking here about high-quality TAVI or TAVR, I would like to get this opportunity to pass one or two messages here, to some degree expressing also the European Society of Cardiology concerns. It's getting clear that quality is one of the main and important issue in these high-cost therapies. Value-based medicine is something spreading in the United States and to some degree in Europe. And cost-effectiveness is another big issue. So I would like to pass a message saying, yes, it is very important to examine the high-volume centers versus the low-volume centers, but at the same time, it's getting clear that we need well-organized surveys for the follow-up of the patients. This is one. Second, we have to take into account that we have to use well-organized criteria evaluating the comorbidities of these patients. For example, 86 years old patient with dementia or borderline dementia or very mild dementia. What does it mean for the healthcare system and for the physicians personally?
Thank you. Thank you. We are going to continue now.